Alrighty, this is chapter 3, Abdomen, out of Bontrager's textbook of radiographic positioning and related anatomy. And this is the second half of recorded lecture from chapter 3. So this actually is going to start in your book on page 121. Okay, chapter 3 is all about the abdomen, and so far we've looked at the anatomy of the abdomen. We've talked about the patient prep as far as having this kind of x-ray. We've talked about pediatric patients, geriatric patients, obese patients, and the different considerations made for each. We've talked about markers, radiation protection, and the quadrants. We've talked about all the beginning portion of this chapter. And then starting on page 121, as far as positions, we've only looked at the AP supine abdomen, which is sometimes referred to as a KUB, which stands for including the kidneys, ureters, and bladder. And now we're going to look at some of the other additional abdominal views that can be ordered. Okay, so some of the different positions of the abdomen, they can order an upright abdomen, which sometimes can be referred to as an erect abdomen. They can order a decubitus abdomen, and that could either be a lateral decubitus or a dorsal decubitus. They could order just a lateral abdomen. And then there also is something called an acute abdomen series, or an AAS, at the end of this chapter. So in addition to an AP supine abdomen, you could also have the upright abdomen, a lateral decubitus, a dorsal decubitus, a lateral abdomen, or an acute abdominal series ordered on a patient. And there is no real such thing as a routine abdomen. Depending on what you're looking for would actually determine what views the physician actually ordered. So whether you're looking for air fluid levels, those views would be different than if you were looking for, let's say, kidney stones or a foreign body or something along those lines. So with chest, there was a thing called a routine chest, which included a PA chest and a left lateral chest. But with abdomen, there is no such thing as just a routine abdomen. With abdomen, it really depends on what you're looking for as far as the patient is concerned as to what actually is ordered. So let's start looking at some of these positions in this chapter. And we'll start on page 121. And notice at the top it says a lateral decubitus position, and it calls it an AP projection because in this particular picture, the woman is in an AP projection. And remember, projection is the path of the central ray, meaning if you were the central ray, how is it passing through the patient? And in this particular picture, it is passing AP through the anterior aspect first, and then the posterior aspect. As far as the position, she is in a left lateral decubitus, meaning she is lying on her left side, and she's on her lateral side, meaning the left side is down. And a left lateral decubitus, decubitus implies that it is a horizontal beam. Okay, so this particular picture, she's in a left lateral decubitus, and I will tell you that the left lateral decubitus is the most common position of the abdomen that we take as far as a decube. When we talked about chest decubes, we said that we always do both. With abdomen, we don't necessarily do both. We most likely are to do a left lateral decubitus abdomen if they order a decubitus view on the patient. When we look on page 121, some of the clinical indications would be an abdominal mass, when you're looking for air fluid levels, and possible accumulations of intraperitoneal air can be demonstrated. Okay, you can also demonstrate small amounts of free intraperitoneal air. And notice that it says that if you're going to do decubitus, the patient has to be on their side a minimum of 5 minutes before the exposure. So minimally 5 minutes lying on their side to allow all the air and the fluid to layer out. If able to, 10 to 20 minutes is preferred. If that is not possible, though, to wait that time frame, then 5 minutes would allow the air to rise and any abnormal fluids to accumulate or fall. Because anytime you're looking for air fluid levels, you're either going to be doing an upright exam or a decubitus, which implies that it's a horizontal beam. The reason that the left lateral decubitus is the most popular is because in a left lateral decubitus, if there was any free intraperitoneal air, you would actually visualize it on the radiograph between the liver and the right hemidiaphragm. So any free intraperitoneal air is going to rise, and it would place it between the liver, because the right side is up, and the right hemidiaphragm. So it would be between those. The reason that we don't do the right lateral decube as often is because of the gastric bubble, which is typically always present in the stomach, which is typically on the left side. So you don't want to confuse the gastric bubble with free intraperitoneal air. And typically patients always have air in their stomach because of the fact that we talk, we breathe, we chew, some patients smoke. So you tend to always be swallowing small amounts of air, and then it would actually accumulate in the stomach, and it would rise when the patient is upright or lying on their side. Now, ideally, if you have too much air in there, then the patient would typically belch. Okay, but most humans have some amount of air in their stomach at any given time. So if we were to do a right lateral decubitus, the gastric bubble could be confused with free intraperitoneal air. All right, so minimum of 5 minutes, she should be lying on her left side in order for all the air to rise and the fluid to fall. This is done at a 40-inch SID, and you're typically on a 14 by 17 IR placed lengthwise to the patient. Okay, her habitus is such that if you were to place it lengthwise, that would be acceptable. So lengthwise to her, meaning that this right here, this would be represent the 17 inches long, and this is the 14 inches here. Okay, so 14 inches this way, 17 inches this way, lengthwise to the patient. Now, our technique for this is going to be 80 kVp at 12.5 mass, which is a little bit more than our AP supine abdomen. But now, when the patient lies on their side, gravity is not going to really help you because all the tissue is still going to remain on the patient. It'll just fall forward. When we did the supine abdomen, the tissue tend to fall to the side and make the patient thinner. This isn't going to make the patient thinner. It's just that all the abdominal tissue will fall forward. So we need a little more quantity of photons to get through that patient. So 80 at 12.5 would be a good baseline technique. As far as the patient, they're lying on ideally some kind of pad on their left side. Their knees can be flexed to help them alleviate some of the low back pain and to kind of keep them a little more steady. And you want their arms up out of the way so that they don't obscure pertinent anatomy. And then you adjust the patient either on a stretcher or on a table so that the central ray is going to be placed 2 inches above the iliac crest at midline. All right. Now, this central ray they're showing you in the book and on this slide is not correct because this central ray is at the iliac crest and midline. Where we want to see it is 2 inches above. So that's what these arrows are trying to indicate to you that I put on there, is that the central ray should be 2 inches above iliac crest and midline on this particular image. So this line right here should actually be right here. approximately 2 inches above the iliac crest and midline. Right, midline with her xiphoid process. So 2 inches above iliac crest and midline, and the reason for that is because that will include the diaphragm. And remember, the diaphragm is the superior border of the abdomen, and the inferior border of the abdomen is the pubic symphysis. So in this view, when you have air fluid levels, you need to include the diaphragm on this view. Okay, so 2 inches above iliac crest and midline, your central ray is horizontal, and that's how you will demonstrate air fluid levels. And you make the exposure at the end of exhalation because it is an abdomen. So all chest is done on inspiration, unless they order an expiration chest. All abdomen is done on exhalation. Why? Chest, you want the diaphragm to be at its lowest level, so you do that, accomplish that by breathing in. With abdomen, you want to see as much of the abdominal contents as you can, so you need the diaphragm to be raised to its highest level, and you accomplish that by exhalation. Okay? So central ray is 2 inches above iliac crest and midline. Notice there's 2 lines, so typically on a central ray, I would tell you that you always have to know where this one is placed and where this one is. So the book just says 2 inches above the iliac crest. So it gives you this line. I'm just telling you this one would be in the middle of the patient. Now, when we do that, radiographically, what that would look like is that you would demonstrate the diaphragm, which is right here. You can see the diaphragm better on this side, better on the right than you can on the left, but the diaphragm is on there. You get both sides of the body included, which this is a little bit, to me, a little bit cut right here. You should have a little bit more of the downside. There should be no rotation, no motion, and appropriate exposure factors. Notice they're pointing out the iliac wing on the patient. This is all gas in the intestines. You can see the outline of the intestines, and you can tell that this is either an upright or a decubitus because you have distinct air fluid levels. If we were to draw on this, see how you've got nice sharp lines like this? That means that is a distinct air fluid level, meaning that the patient is on, in this particular image, on their side because of the way you can visualize that. When we look at the upright, I'll show you what I mean by that as well. So air fluid levels definitely visible on there because of the way the patient is placed and that it's a horizontal beam. You can see the spinous process down here. This would be lower thoracic and then lumbar spine. And then the different parts, the pedicle, the vertebral body, and the spinous process. So this is a left lateral decubitus abdomen. And if you look on page 121, you can see these same images, one labeled and one unlabeled. This area right here is the liver. All right, and then you can see the dome of the diaphragm. So if there was any free air, you would actually visualize that free air between the liver and the right hemidiaphragm. So if there was free air, you would visualize that right in here, okay, between the liver and the right hemidiaphragm, because the air would rise, and the highest level that it could rise would be the diaphragm. So typically, you're going to visualize it in that area, if there was any. Right? So a left lateral decubitus is the most common. Central ray 2 inches above iliac crest and midline. Exposure on exhalation and 80 kVp at 12.5 mass. Now, if you flip the page on 122, you can see there is an erect abdomen, or what they sometimes call an upright abdomen. So in this case, you're still going to have gravity helping to differentiate air fluids, okay? But the patient is able to stand upright for this, whereas in the last image, the patient was probably not likely able to stand. So this would also demonstrate any abnormal masses. It would demonstrate air fluid levels, and accumulations of intraperitoneal air under the diaphragm. If the patient came into your department and sat in the waiting room or was, upright in a chair, seated on a stretcher, sitting, you always want to perform this exam, this picture first before you lay the patient down, because when we sit, they have to be on their side a minimum of 5 minutes. Ideally, if they drove to the facility and they sat in the waiting room, then they've already accomplished that, being on, upright for at least 5 minutes, which would be good because all the air would rise and all the fluid would fall. Technique on this is still 80 kVp at 12.5 mass. And notice that the central ray on this is correct because they're outlining the iliac crest, and central ray is 2 inches above iliac crest and midline, meaning it's in line with the xiphoid process. And they do tell you that if you do this properly, typically the top of the IR will be at the level of the axilla, meaning if you were to raise his arm, then typically the image receptor would be at about the same level of his armpit. Okay, and that's how you typically know that you're going to be able to include the diaphragm, because this particular image, you have to include the diaphragm as well. So central ray is 2 inches above iliac crest and midline to include the diaphragm, and that says that it also typically places the top of the IR at the level of the axilla. Again, you'll make the exposure at the end of exhalation. So you would tell your patient, take in a deep breath, blow that breath all out, hold it out, don't breathe, and then make the exposure. Now notice, this patient and our last patient both tend to be on the stenic side, which means that they would fit on one 14/17 image receptor lengthwise. That's not always going to be the case, and we'll talk about that in just a few minutes. Okay, when we take that image, as far as the criteria we're looking for, the diaphragm has to be included. Okay, and you can see right here, they've got the diaphragm included on there. Left hemidiaphragm sits lower than the right because of the liver. There's no rotation. There's no motion. The exposure factors look acceptable. And again, we have this distinct line that shows us air fluid levels. So you've got air up top. Any fluid would be on the bottom because air tends to be radiolucent. Fluid tends to be more radiopaque. So you definitely can tell that this was done upright because of those sharp lines, similar to when we did the decubitus view, and you've got these distinct lines. If you didn't have distinct lines, then the image probably was not done upright or in a decubitus position. Okay. Notice they have left marker, which typically we will always try to use left marker unless it's a right part or you're unable to use the left marker. Okay. The technique on this was 80 at 12.5, so this looks acceptable because they're looking for, again, is any free air between the liver and the right hemidiaphragm. So no air is seen in there, but if there was air right in this area, that would be the highest level it could rise because it couldn't go above the diaphragm because it's trapped in the peritoneum. Okay, so it would rise right here between the liver and the right hemidiaphragm. And that would be your either left lateral decubitus or an erect abdomen. The next position they look at is a dorsal decubitus, and this is on page 123. A dorsal decubitus, remember that dorsal refers to the posterior aspect of the body. So a dorsal decubitus means that the patient is lying on their back and the beam is horizontal. So this is called a dorsal decubitus, and technically this particular one is a right lateral dorsal decube. Now why do I say that? Because her right side, so right lateral, is touching the image receptor or closest to the image receptor, So right lateral, closest to the IR. She's on her back or the dorsal surface, and it's a horizontal beam. So she is in a right lateral dorsal decubitus. Okay. One thing I did not mention that I intended to on these decubes, anytime you have a decubitus, you always mark the side up. So in this particular image, they should have a right marker, which I'm quite sure that's what this is. But you would want right side marked because the left side is down. In this particular image, in this decubitus, you would also mark right because her right side is closest to the IR, and that's what that marker. That marker is a right, that marker says decube. So you would mark right because it's a right lateral dorsal decubitus. Your central ray is still 2 inches above iliac crest, and now it's considered mid-coronal. Okay, so mid-coronal. So this is not correct in the book either. This should be 2 inches above iliac crest and midline. So this line, this crosshair should be 2 inches higher than what it currently is. Why? Because we need to include diaphragm on this particular image. And the only way you're going to include diaphragm is if you place your central ray 2 inches above the iliac crest and mid-coronal, which is still midline. You're just looking at it midline from anterior to posterior aspect. Okay? You still suspend at the end of expiration. And this technique requires a little bit more. So this is actually 80 kVp at 25 mass. All right? And again, this is done to show any abnormal masses, any accumulation of gas or air fluid levels. It can also demonstrate aneurysms, any calcifications in the aorta or other large vessels. And it can also demonstrate an umbilical hernia. Okay, so a right lateral dorsal decube. And as far as our radiographic criteria, we do have to include the diaphragm. Now this, you can see it here, you lose a little bit here. So ideally this would include the entire thing. Like maybe if this image came out just a little bit further and you could see that entire diaphragm. Now it's probably warranted to be okay because you can see it right up until about here and you pick up right here. And I don't see any free air, but if it was supposed to be a really diagnostic image, that should include the entire diaphragm without question. There should be no rotation, no motion, and you can look in the spine and tell that there's no motion, no rotation because the posterior ribs are right on top of each other. And the exposure factors look acceptable, which was probably 80 kVp at 25 mass. Okay, you can see some air in the intestines here, a little bit here, but otherwise that looks really good. And sometimes what they'll do this for is after the patient has a AAA repair in the OR. Remember, a AAA is an abdominal aortic aneurysm. So sometimes when they repair that aneurysm in the OR, they'll actually send the patient down to radiology to have a dorsal decubitus view done to make sure that they can visualize the repair to the aorta. Usually you'll see like a kind of mesh covering where the aneurysm was or is. They'll usually just evaluate that after surgery. All right, so far we've done a dorsal decubitus, an erect abdomen, and a lateral decubitus. And all of those are done to demonstrate air fluid levels, okay? Our next image is simply a lateral abdomen. And this is found on page 124. All right, and a lateral abdomen is simply with the tube up above. if we had the tube, it would literally be over the patient at a 40-inch SID. You would see the tube head assembly right there, and the beam is coming down like this. All right, in the other views that we did, or we looked at, you would basically have the tube over here, all right, and your beam is coming through the patient horizontally. Same thing with the decubitus view. The tube would be over here, and the beam is shooting horizontally across the patient. Okay. On a lateral abdomen, again, you call this by the side that is down. So this is a right lateral abdomen. Again, the central ray is not correct. The central ray should be 2 inches above iliac crest and midline. Not sure why they printed this entire book with all of those incorrect, but make sure that you look and note that it should be 2 inches above iliac crest and midline. This is done for any abnormal soft tissue masses, an umbilical hernia, to evaluate for aneurysms in the aorta. You could also do this if you were trying to localize a foreign body that maybe the patient swallowed. Your technique is still 80 kVp at 25 mass. And again, this patient is likely to be done on one 14x17 lengthwise. Central ray is 2 inches above iliac crest at mid-coronal. And anytime you're 2 inches above the iliac crest, your diaphragm is going to be included. So radiographically, you have to include the diaphragm. There has to be no rotation, no motion, and your exposure factors have to be acceptable. Okay? The reason this has a right marker, again, is because they are in a right lateral position. So if they're in a right lateral, you have to use the right marker. All right? And this is found on page 124. Now, going back to, like we had discussed with an AP supine abdomen, if you went to your patient and they were not stenic, they were hyperstenic, and you had to do 2 IRs placed crosswise to each other, just like we did when we talked about the AP supine abdomen, what you would do on that is actually place your IR crosswise to the patient, okay, meaning it would be 17 this way and 14 over here. And we know that on the left lateral decubitus, on the erect abdomen, and on the lateral abdomen, we have to include diaphragm. So typically what you would do if your patient did not fit on one IR, you would start with the top picture first. You would place your top IR so that you were including the diaphragm, and then you would end up, when you took your second image, you would have 1 to 2 inches of overlap, okay, like we talked about with the KUB. So if your patient is hyperstenic and they will not fit on one image receptor, it is possible that you'll take 2 IRs crosswise to each other to capture all of the anatomy. But what I'm telling you with these views that we've talked about so far, your first image would be up top so that you included the diaphragm, and then your second image would be at the bottom. So if we try and draw this out and I use something other than red, you would start by doing 1 crosswise IR to include the top. And then you would place your fingers in the bottom of the light field, 1 or 2 fingers in the bottom, and you would take a second IR so that you overlapped. Okay, so everywhere in here would be overlap on the patient. So when you have two images placed crosswise, you don't really have a specific central ray. Your first image is always done to include the pertinent anatomy that you need, and your second image is taken so that you can prove you have overlap on that anatomy so that the radiologist knows you're not missing anything as far as the anatomy is concerned. Okay, so all of those we talked about, whether it's left lateral decube, an erect abdomen, a dorsal decubitus abdomen, or a lateral abdomen. If your patient does not fit on one image receptor, you would do two, but your image would start at the top to include the diaphragm. All right. In this last section, they talk about clinical indications for what's called an acute abdominal series, or an AAS. Some of the reasons a patient might have an AAS, which is usually 3 views, and I try and tell you guys, an AAS has 3 letters, so there's 3 views. There is always 1 view of the chest and 2 views of the abdomen. But it depends if your patient is able to walk and talk or if they are non-ambulatory. All right? If the patient has a suspected ileus, which is a small bowel obstruction, okay, if they have ileus or they have ascites, which is an abnormal fluid in the abdomen, I usually call it a doughy abdomen, or they have a perforated hollow viscus, meaning the bowel is perforated or their stomach is perforated, which allows for free intraperitoneal air, or they have a mass in their abdomen, or they are post-op abdominal surgery, then they might order an AAS. Let's say your patient is able to walk and talk, like they can come down to the department and they're able to stand and do all of that. If they are able to walk and talk, then what we would do is a PA chest, an AP erect abdomen, and an AP supine abdomen. Those are our 3 views for an ambulatory patient, and they're done in this order. You would do the PA chest first, with the patient upright at a 72-inch SID. Then you would do the AP erect abdomen by coming into a 40-inch SID, with the patient still erect. And the last image you would do would be to lay the patient down on the table and do a 40-inch AP supine abdomen. Okay, so if they're able to be ambulatory, this is what you would do, and the order would be the PA chest first, then the erect abdomen, and then the KUB, or the AP supine abdomen. If they were not ambulatory, okay, if they are not ambulatory, then the first thing you would do would be, for non-ambulatory, you would do an AP chest, you know what, let me erase that and try something else. Okay, if they're non-ambulatory, then you would do first an AP chest. Second, you would do a left lateral decubitus abdomen. And third, you would do an AP supine abdomen. Okay, so that is for a non-ambulatory patient. Non-ambulatory, you would do AP chest, left lateral decubitus abdomen, and a supine abdomen. If they were ambulatory, then your first one would be the PA chest. Second would be an upright abdomen. And third would be an AP supine abdomen. So this particular one is non-ambulatory. This one is ambulatory. Now let's talk about why. Let me just write real quick. So this is non-ambulatory. This one is ambulatory. Now, we have to have one chest view. So if they can walk and talk, then a PA chest is what we want. If they come in on a stretcher and they're not able to stand, then we're going to have to do the AP semi-erect chest x-ray because that's the next best thing to a PA chest. So that would accomplish both of our chest views. Then we need an abdominal view that'll demonstrate the diaphragm to show air fluid levels. So if they're able to walk and talk, an upright abdomen would be ideal. If they're on a stretcher and they're not able to get upright, then the left lateral decubitus abdomen would be able to demonstrate the air fluid levels that we would need to show. And then note in both ambulatory and non-ambulatory, we are able to perform an AP supine abdomen. Okay, so if they're ambulatory, PA chest, upright abdomen, AP supine abdomen, non-ambulatory, AP chest, left lateral decubitus abdomen, and then an AP supine abdomen. And that is for, remember, that is for the patients that have suspected ileus, ascites, a perforated stomach or bowel, any intra-abdominal masses, or their post-op abdominal surgery and they're looking for free air. And if they come to the department erect, you always want to do those images first because remember they have to be upright or on their side for a minimum of 5 minutes so that the air can rise and fluid can fall. All right. Now sometimes what they do is they'll offer a two-way abdomen, or sometimes it's referred to as a flat and upright. If they order a two-view abdomen, typically you would do an AP supine abdomen and then an AP erect abdomen. That, again, if they're able to come in walkie-talkie. If they're in a stretcher and they're an inpatient and they're really, really sick, then you would likely do an AP supine abdomen and a left lateral decubitus because both the decubitus and the erect would demonstrate air fluid levels. Okay, and that's what you're trying to demonstrate with that is because it'll include the diaphragm and it'll show any free intraperitoneal air or any air in the abdomen that is able to rise and or fluid will be able to fall. All right, so when we look at this, a two-way abdomen, ideally, if they are able to be ambulatory, okay, we do a supine abdomen, which does not require the diaphragm. Okay, supine abdomen, you include pubic symphysis because that's the inferior border of the abdomen, but it is not required to include the diaphragm on an AP supine abdomen. And then you would do an erect abdomen. And again, notice the air fluid levels. Notice how in this one you can see air, but they're not presented distinctly like this where you can tell that the air rises. This one, patient is lying flat on their back. So this is an AP supine. This is an erect abdomen. So this patient was able to come in, walk, talk, got there on their own accord, and we were able to do that. If this was not able to be accomplished doing it upright, they could do a left lateral decubitus. Okay, so on AP supine, this is what they look like. Lying on their back, 80 kVp at 10 mass, central ray, iliac crest, and midline. That is assuming you're on one image receptor lengthwise. If they wanted two views, this would accommodate the flat or the supine. And then if they're able to stand, this would accommodate the erect abdomen with the patient properly centered, central ray 2 inches above iliac crest and midline. Technique would be 80 kVp at 12.5. And again, this is assuming you're on one image receptor lengthwise. If they could not stand, then you would replace that with would be your left lateral decubitus. Again, with this central ray not correct, the central ray should be 2 inches above iliac crest and midline. So not this one, but this one. Okay? Central ray right here, 2 inches above iliac crest and midline to include the diaphragm if they could not stand. And then the other view, if it's a AAS or a 3-way abdomen, remember we're going to do a PA chest with the central ray at T7, which is found at the inferior border of the scapula, the inferior angle of the scapula, and midline. So if it was a 3-way abdomen, you would start and do the PA erect chest. Then you would do the upright abdomen. And then finally, you would do the supine abdomen. That would be the 3 views on an ambulatory AAS. Okay. All right, we do have some radiographs that we'll look at critique during our live. So hopefully you took notes on that and looked at the pages that goes along with that. The AAS is on page 125. And if you have any questions or comments or concerns, I do hope that you're writing those down. And hopefully I can help clear that up when we next meet. Thank you very much.